Our speaker tonight is Dr. Shawn Griffin. Shawn is a family practice physician who is in practice in Missouri for 12 years. In addition to being a family physician, he is a self-confessed computer nerd. So 5 years ago, he was hired away by Memorial Hermann Hospital in Houston, where he is currently the Chief Quality and Informatics Officer. He's been a major participant in the development of their clinical integration model, which, as I alluded to earlier, is about 5 years ahead of where we are now. I think he's going to bring a lot of insight into what we can expect moving forward. I had dinner with him last night, and I learned at that time that he's the father of 5, that he has a passion for quality in medicine, and has been able to merge the practice of medicine with the measurement of that quality. Shawn?
First of all, I'd like to thank the esteemed people here up on the dais for letting me come tonight. This has been fun. I would complain a little bit about the weather for my first visit to Richmond. Today was not the most beautiful day to be walking around the state capitol, but the people have more than made up for it. My goal tonight is to inform you, to challenge you, to provoke you a little bit, to raise some things that you might have wondered about before. But it's also to share my passion. I'm a bit of an evangelist when it comes to clinical integration, not for the sake of clinical integration, but for the sake of physicians using this opportunity to drive quality in their offices and in their organizations. One of the classic things that I use as an example is how many of the physicians here believe that they're good quality physicians? Raise your hands. I wonder about those of you who are not raising your hands if you're physicians. The next question is, how many of you have the data to prove it? I'm not asking you about, a particular measure or those sort of things, but how many of you really know what your quality looks like on paper? Because every single physician in the room has a score, has some measures that are attached to their name. Now, I'm not talking about if Mrs. Johnson likes you as a doctor because you sit and listen. I'm talking about in those back rooms in the government, in those back rooms in the payers. There is something attached to your name, whether it be a score, an A, B, or a C, or a percentage number, or those sort of things. But your quality is out there. Whether good, whether bad, whether you've been paying attention to it or not, your quality is out there. Somebody is judging you based upon what you have put out there. The new rules of medicine. To some people they aren't new, to some people they are. Change is here, but it is just the beginning, okay? I can tell you if tomorrow the Obamacare, or whatever you want to call it, goes away, change is here in medicine and it's not going away. We have payers, independent payers in our market in Houston, yes, it's Houston, pushing us to change how we practice medicine, who want accountability, who want population management. Physicians weren't generally trained in population management. Physicians generally were trained on patient management. And I say physicians are great with patients, they're good with their practice, and they're lousy with populations in general. We don't tend to think of populations, okay? It's not measured by volume, by diligence, or even skill, your quality. Now, parts of it are. Some of these things are meant to be a little provocative. Value in healthcare means achieving good outcomes as efficiently as possible. How's your efficiency? In your office, how's your efficiency? How do you even measure your efficiency in your office? Okay? Would your office staff say that you're efficient? What would they say about you behind your back? And teamwork is a required function these days for a physician. Okay? If you are not part of a team right now, you will be. And if you don't know how to play on a team, you're a problem. And it may get in the way of you doing the job that you want to do because you aren't doing the things you need to do. Let me give a little bit of organizational background. So this is Memorial Hermann Healthcare System, okay? We are the largest healthcare system in Houston, Texas. We are 9 locations, 12 hospitals. This is all of our plaques that show up in our trophy case, the ones that are most impressive. I never put too much stock in the 50 or top 100 hospitals or those sort of things, because if you look at it around the country, there's actually 7,000 hospitals that are top 50 in various measures. The National Quality Forum Award and the Eisenberg National Patient Safety Award, we're the only organization in the country to have won both of those. Delivering healthcare that works. This is the cover of our value report that we issue every year that summarizes what we have done as an organization. And we put it out there for payers, we put it out there for employers, we put it out there for our physicians. And when you open up this glossy, about 20-page document, and I have a copy in my bag, one of the things I want you to know is that every picture in there of a physician is one of our physicians. It's not a stock photo. Because our physicians are proud to be part of our organization. And not just because we have the coolest jackets in the hallways of the medical schools or anything like that, but because our doctors are engaged in quality. This is our mission statement. Transformation of medical practice, collaboration with patients, payers, and caregivers, use of evidence-based medicine, culture of physician accountability. I believe physicians are being held accountable for what they do in the practice of medicine, and I do not believe there's anybody better than other physicians to be part of the measurement team. And if you wait until, if you have nothing to do with quality and you go about continuing to practice medicine, the first time you're gonna see your quality numbers is when they're on a billboard or on a website that somebody else put up there. We believe in quality, safety, and cost efficiency, and we manage populations. This is our corporate structure. It's a beautiful corporate structure sort of slide. The point being is that our corporate structure is underneath the Memorial Hermann organizational umbrella. And as I was talking to some people this morning, and I said, if you want to believe that we're just puppets of the organization, then there's the proof, because we're underneath their umbrella. But if you want to believe that we're actually run by the physicians, there's proof. It's right there on the slide, because we are not them. We are we. We have 24 physicians who make up our board of directors and who make the decisions for our organization. I do not answer to the Memorial Hermann Healthcare System CEO. He's a good guy. I don't answer to him. I answer to 24 physicians. And they are generally, I think 90% of them are independent practicing physicians. To understand where we are and what we've done, you have to understand where we're growing. What's the environment, okay? The Houston market has very little physician consolidation. When you look at our 2,000 physicians, the average practice size is about 1.8 to 2 physicians. We have 4 main hospitals. We have splitters among our specialists. We have secret splitters who, if you ask them, they have a majority of their cases at 4 different hospitals. They're incredibly loyal to whoever they're talking to. And our commercial rates are among the lowest in the country, 80% of Medicare. Are you guys doing better than that? Good, okay? So when we put together clinical integration, we actually had to adjust it to this market. So when we sat down with the physicians, we talked about where they were hurting and things that we could help them with. This is the market that we were talking about, and we have a high uninsured population. Okay. So now here I'm saying MHMD, the Memorial Hermann Physician Network, has 3,900 physicians directly employed by the organization. By Memorial Hermann is less than 200. Okay? So every year we have to prove our value as an organization to a lot of independent physicians. We can't just tell them, you do that because we sign your paycheck. Okay? We have done studies that show that a physician who's part of clinical integration through MHMD has a higher contribution margin to the system than an employed physician does. Physician employment does not mean that they are engaged any more than taking a tiger out of the zoo and putting it on a chain makes it a pet. And when it came time for us to sign up for an ACO, which is where we progressed through clinical integration, we had about 2,000 who opted in to sign up for that. And it's a Medicare shared savings ACO, which means there's primary care exclusivity. That's part of the picking of teams that's going on right now. If you have Medicare shared savings ACOs, a primary care physician can only be in one of those. So you're seeing alignment being forced as they have to pick a team if they're going to be in one. We've been doing this for years, and yet we're still learning every day. We started back in the 1950s. It was our medical staff that basically made up our organization. We formed an IPA in 1983 because everybody was forming an IPA in 1983. Clinical Programs Committee started in 2000, Clinical Integration 2005, and an Accountable Care Organization in 2011. Okay? Each of those decisions has been appropriate for the time, but has been revisited I mean, there was a time 10 years ago where we almost shut down the IPA because it served no purpose for our physicians. And now it's a key component to where we have talks with bond rating agencies. They ask our CEO how he gets along with the physicians and how clinical integration is going at Memorial Hermann. Here's a history slide. It's not particularly thrilling. We committed back in 2005 to clinical integration. In 2008, we actually wrote a compact for our physicians because we believe that it's not just about a contract, it's about rules for engagement, how we're going to relate to each other. And our first contract with the hospital system employees, a willing partner, we're going to eat our own cooking to see how we do with this as a trial run. I think you'll see that in a lot of clinical integration. When we went to market, only 1,200 signed up for clinical integration out of 3,000 or whatever it was at the time. 1,200 signed up for it. And you need to understand how that happened. We went to our physicians and we said, we're going to do clinical integration. We're going to measure your quality. We're going to share it with each other. We're going to work to improve it. And we're going to contract together. Who wants to sign up? How we describe clinical integration. Clinical integration, in case you face a quiz someday, if the FTC comes in here and says, what's clinical integration? It's an FTC recognized quality improvement program. Okay? That's the most important thing about clinical integration. It's a quality improvement program. It's not a contracting vehicle. It's a quality improvement program. And our organization has discovered that we can use clinical integration to improve quality throughout the system, not just to get contracts for physicians. I was talking to one of your physicians today, and he said that when he talks to physicians, sometimes they talk about, well, I would do that, but I can't because. Our job at MHMD is to get rid of the things the physicians say they can't do. Okay? We want to take away the physician reasons why they can't own quality wherever it is in our system. When we write contracts, it's generally going to be a shared savings contract with an incentive bonus pool. That's the classic sort of way of doing a clinical integration contract. I think you guys are doing some of that also. Physicians have to report quality. If the FTC were to come in and talk to your organization and they would say, what are you doing differently because you're in clinical integration? And the physician sort of shrugged their shoulders and said, I don't know, nothing really. That's not clinical integration. You have to be engaged in a quality improvement program. So in year one, we went very simple. And the reason why we went very simple is because I'm a simple guy. Our first bonus was tied 50% to reporting quality metrics and 50% to taking a CME program. The CME program was what is clinical integration. So we did all the crimson connecting and reporting and all those sort of things to get PQRS measures collected. The second year, it was for reporting quality metrics. It was for CME completion. It was now 6 CMEs if you wanted to earn the bonus. And we looked at campus-based use of evidence-based order sets. Not just you, Dr. Jones, but your whole campus, how they do on using order sets. So if you were a primary care physician who had no cases in the hospital, you still checked to see if your hospitalists were using the order sets because you had money riding on whether they did or not. It's that team idea. Now when we sit down and we're looking at designing a bonus program, we generally, shared savings is part of it, but we also want to tie things specifically to quality metrics because our physicians recognize a couple things. Shared savings as an idea goes away. You eventually pull all of the savings out of a contract. And if you're not focused on quality, you run out of money that makes it worth doing the work that you're doing. So we will actually do 2.5%, 3.5% of the contract value tied to quality metrics. So whoop-de-doo, that's our design. What are we getting for this? What are our physicians getting for doing the work? Let's talk about the value to payers. So this is Memorial Hermann quality metrics year-over-year change, okay? All of those green ones, you don't need to pay attention to the numbers. Those are all improvements, okay? Those are improvements in things like asthma meds, cervical cancer screening, breast cancer screening, colorectal cancer screening, diabetes, hemoglobin A1C rates for a population. Putting in the people, the processes, and the technologies to improve those numbers. Now, if anybody ever stands in front of you and only shows you green numbers, they're fooling you. The red ones are things where we did worse year over year. If somebody's data looks too clean, it means somebody polished it and got rid of the ugly parts. Your data should have ugly parts. Okay? 7-day post-discharge follow-up dropped. okay? And most of the time when a quality metric gets worse as part of a program, it means that you've broken how you're measuring it. It's not like our doctors suddenly stopped seeing the follow-ups, but they stopped checking the box that meant they'd seen the follow-up. So how do we compare to the market? Well, admits per thousand, MHMD is in red, the Houston market's in blue. We're better at admits per thousand, lower length of stay, lower impactable admissions, lower readmission rate, lower ER visits per thousand, lower avoidable ER visits per thousand, and our generic prescribing is less than the market. Again, I want to show you the mistake to prove to you that the rest of it's real. Okay? So if you're a payer and you have a chance to contract with physicians with lower length of stay, lower readmissions, lower ER visits, is there a value there for you? It's a cheaper team. Okay, it's going to save you money. And if the quality is better and the cost is lower, the payer wants to come make a deal with you. And that's where we are as an organization. The Memorial Hermann CI network has better overall clinical outcomes than the greater Houston market. Our costs are lower, our clinical organization infrastructure is more advanced, our outcomes are recognized by the payers. Those numbers that I showed you for us compared to the market, those were not our numbers, those were the payers' numbers. So this is not just that I made it look all good and shiny because I had the data, it's they're coming to us and saying when we look at our numbers, they agree with your numbers. So what difference does this make for the hospitals? Okay, we actually came up with a program called the Inpatient Quality and Safety Initiatives. Okay, and this is looking at order set usage, electronic order set usage, iatrogenic pneumothoraces, PPEs or DVTs, hospital-acquired infections, serious safety events. And we went through and we valued those events. If we make those things better or you know, whether it be more frequent or less frequent in a good way, what does that mean to the hospital system? Does it save the system money? Because our physicians can work together as a team, because we're giving them the tools, we can make a difference year over year in things like hospital-acquired infections, 12% lower. Because our physicians are driving what needs to be done. Serious safety events, 13% lower. Okay? Iatrogenic pneumothoraces, 68% reduction in those. Those quality awards I showed you on the first couple of slides are because our physicians are part of the quality team. All of our physicians, and they're doing things like this. So whatever you thought clinical integration was, whether you thought it's some program where I check the PQRS boxes and I get a possible bonus pool, understand, clinical integration is a tool. What do you want to do to change the quality of the medicine that you practice for the entire community? This can be your tool, but not if you just dabble in it, not if it's just a hobby that you do or you push it off on your MA to check the boxes. But if you had this, if you had a team of physicians who had the authority and the responsibility to drive quality in your organization, what could you do? It's one of our hospitals, and this is the iatrogenic pneumothorax rate before we started the program. Okay? These things happen. We all went through training. These things happen. You know, they occasionally happen. There are known risk for doing some of these things. They happen. Until they stop happening. Until you go 20 months without an iatrogenic pneumothorax in your hospital. All those things that you were trained always happen in medicine don't have to always happen in medicine. Now I want to give a provocative story here. We had a problem in our organization with foreign bodies left in patients. Okay? You may have had this at your facilities. So number one, we try a rule. Surgical cases should not close until the counts are correct. Did that make them all go away? No. Okay, well the nurse is to not help to close the patient. There, that'll stop it. No. We bought RFID equipment and little wands to wave to see if the tummy beeps. You know, you left a sponge in or something like that. Did that make it go away? No. What made it go away for us as an organization is we said to the nurses in the OR, no foreign bodies is a condition and an expectation of your employment. If the physician closes and there's a foreign body, you're fired. Is that a little provocative? Okay. Now what happens in the OR? Does the doctor want the nurse to be fired? No. But that's what it took to make the doctor stop until they checked everything. How many nurses have we fired because of this? None. But foreign bodies being left in has pretty much gone away. Okay? That's what, what are you going to do when you've tried everything else? What are you going to do? We had to invent a new award called the Certified Zero Award for high reliability as an organization. If you've heard Dan Wolterman or Michael Shabbat talk around the country now, they're talking about high reliability, where we expect Memorial Hermann to achieve the levels of reliability that you see in nuclear submarines or aircraft travel. Good aircraft travel, I should say. Zero central line bloodstream infections for 36 months in a facility. That's pretty impressive. 12 months without something, 36 months without something. These are our system numbers for central line associated bloodstream infections. Those of you who are familiar with statistics will notice how this run chart keeps going lower, and the parameters are getting lower, and they're getting smaller, and the numbers are going down. Each time you see those different red bars is we've redefined where the normal range is for these things. And that's not because we bought the latest wonder drug or the electromagnetic spongeathon or something like that. That's because our physicians are engaged in driving these numbers. So I've showed you maybe 4 or 5 examples as to the Certified Zero Awards. This was made up last month. We have 91 different Certified Zero Awards that we have awarded throughout our system for making things go away for 12 months at a time. TIR, ventilator-associated pneumonias, none for 60 months. Would you want to be part of an organization that is empowering the physicians to change the safety in that way? These awards, when they're given, the surgical awards, they get posted by the OR. They're in the physician's lounge. These are celebrations. The reason why this is important is because it's time for organizations, especially hospitals, to get off of their bikes with training wheels. Okay? And by that I mean core measures. If you're in a hospital and you have a good month of core measures, everything perfect, it's a cause for celebration. Okay? I don't think Southwest gets together at the end of the month and said, nobody crashed, way to go. The government recognizes that core measures are not an achievement, they're an expectation. And now when you start missing those, you're going to pay a penalty for it. It's not, here's your reward, good job. The way that this matters is if you've looked at the inpatient value-based purchasing that CMS is doing, what you'll notice is that there's these domains for efficiency, outcomes, HCAHPS, and core process measures. Core process measures starts out as 70% of your payments for 1% of your payments at risk. It goes down to 10% when almost 2% of your payment is at risk. They're not going to pay you to do well on your core measures anymore. Efficiency, outcomes. Are you ready for 40% of your inpatient payments from CMS to be tied to your outcomes? That's where we're going. And you know what? Every single thing the government has ever done to change inpatient payment systems, they have then rolled to outpatient payment systems. So when we started doing PQRS reporting, our doctor said, oh, this is a burden. I don't want to do this. This is cumbersome. Now, if you're not doing PQRS, you're going to face a pay cut from CMS. So the benefits to the hospital system. Physicians lead the efforts to improve quality and safety. We actually have an increased market share with contracting. When you have high quality and low cost, the payers want to steer patients to your system. And as admissions per thousands decrease, unless you want to close beds, you need to increase your market share. Where are the lives going to come that feed the population, that feed the decreased utilization, that keep your units open? Okay? The other thing is if you have a hospital that doesn't have anyone refer patients to you, you will not do well. You need to have alignment with your community PCPs or they're not going to send you any business in the first place. And hospitals face penalties for readmissions. The way to take care of readmissions is you do a good job when they're in your house, and when they leave, you do a good job, and when they're out in the community, you do a good job. If you think that you can fix readmissions just by having a really good discharge process, you're insane. So where are we right now? Clinical integration, 1,952 doctors under the umbrella, 1,388 specialists, PCPs 564, and APCPs, what's that? That's advanced primary care practices. These are ACO physicians who are having us come in and improve their quality in their offices. Patient-centered medical homes, NCQA level 3 at a minimum. We're going into this. And we only have 100 doctors in the medical group employed. So you move from messenger model contracts to clinical integration to advanced primary care practices to an ACO. You will not make this same journey. Let me be clear about that. I'm just telling you the journey that we saw in the Houston market and the things that we did. The value to the docs, quality incentive. We will help you make your quality better. We will put people in your office. We will give you worksheets that you need to understand. We will help you with your coding. We will collect the information. We'll tell you how you're doing every 6 months so you don't just find out when the government shows up and gives you your grade at the end of the year. We'll help you fix your EMR so that it's reminding you of the quality measures, but it's not popping up a box every time so that you ignore it. Market steerage of preferred commercial lives. Well-paid, fee-for-service lives going to our doctors because the benefit design changes to push the people to our docs. It's worth market share. It's worth good lives, not just some, 50% of Medicaid sort of lives. Good lives that the doctors want to have, good people. Practice support to improve outpatient quality, alignment to improve quality for inpatient care, consistent quality metrics for multiple plans. When I was a primary care physician, I had about 6 different plans that gave me their quality programs and the metrics I needed to pay attention to. It looked like a deli menu board. I had, which plan are you on? Your Aetna, your commercial. It's Tuesday, I need to check your mammogram. Okay? What we have is we call measures of excellence. When we sit down with a payer, we have a list of quality measures that we push across the table to them and we say, these are the ones our doctors are doing. You pick some, whatever makes you happy. Because we're going to do all of those measures for all of our plans, and we're not going to do a bunch of one-offs just to keep the doctors busy with trying to remember what they're supposed to remember. This is our patient-centered medical home growth from back in January 2012. We're now up to 279, of which 47 have gone through the NCQA process. We're working with almost 300 practices, 300 physicians to get them NCQA recognized level 3. In some practices, that's filling out the paperwork. In some practices, it's everything. It's getting in an EMR. It's helping them with care management. It's doing the quality reporting. It's patient portal, all of those things. We won't even apply for a patient-centered medical home in our practices unless they're going to be level 3. Because once you're level 3, you get more from the insurance companies on your contracts. Per member per month, higher rates, those things. This is my covered lives slide. The short version of this covered lives slide is that we've gone from 30,000 to about 300,000 in 18 months. We are doing something right that's being recognized by the market, and we're getting good contracts because of it. And when you look at them, mHealth, that's our insured employees, Humana, CMS, United Medicare, Aetna Commercial, and Blue Cross Blue Shield we finally brought to the table. And these are not cruddy contracts. These are contracts that have been negotiated by our physicians, by our contracting committee to give good rates and to have quality incentives or shared savings incentives. Our patient-centered medical home is not some label we stick on the door. We do HCC training, coding training. We help them with their claims filing, electronic medical records, health information exchange, patient education. All of those things make up what we offer our primary care physicians. And this started with a CI program. This started with PQRSs and checking boxes and logging into Crimson. It's people, it's processes, it's technology. It builds. If you had an organization that could come into your practice and help you achieve higher levels of whatever you want to achieve, would you want to partner with them? The doctors come to us now and they say, I saw what you did for Dr. Jones, please come do that in my office. The other thing that this gets into is in care management, there used to be all of the data that the payers had, and there was the data that the doctors had. When we negotiate a contract now, we say, give us all the data. When we write a contract with Aetna, They're going to give us their whole claims file so we can see all of the care that's being delivered to those patients, no matter where it is. I get claims files for ER visits at my competitor's ER because they're our lives. We're taking care of their life, not just their moment in time inside our buildings. And we have care managers. We've gone from 2 care managers to about 20 to 25 care managers. I haven't checked this week yet, that are helping to manage these lives, to manage these populations. If you don't have care management, if you're not ready to populations, you will be left behind in the next 5 years. This is a busy little slide that basically talks about we take claims in, we risk stratify a population, we take the high-risk people, we plug them into an ambulatory ICU model for more intensive outpatient visits, we engage them with chronic disease management. We do behavioral health. We have an oncology home for oncology patients because they tend to be very expensive. We give our doctors reports. We have tremendous transparency. If I were to take one of you doctors and say, I'm going to show your Crimson scores up here on the screen, are you okay with that? Number one, how many of you would know whether it was going to be good or bad? And how many of you would be comfortable in that moment? Well, let me show you where we've gone with it. You know, there's a low-risk population, a high-risk population, a medium-risk population, but all of our lives, all of our hospitals focus on this acute episode. It's expensive, but it's not where most of the care is being delivered. Look at the ambulatory visits. How are you doing for mammograms in your practice, doctor? Well, when a well woman comes in, I do a good job of checking those. Okay, what about if she comes in for a sprained ankle? Are you paying attention to those quality measures? Because all of those factor into your performance in a population. We will not be successful in the future if all we focus on are the catastrophes and the high risk. We also need to do a good job with the low risk. At every stage in care that's delivered to a population, are you efficient and are you high quality? And if you are, prove it. And if you are and can prove it, go get market that pays you well for doing it. We bring the data in, we bring the data up out of the EMRs, we bring it down from the claims, we put it all together, and we give our physicians actionable information. Most physicians are so busy running on the treadmill of daily practice that they don't want a 30-page report. They want, give me the 5 people you want me to take a close look at, and I can do that, but don't just burden me with extra data. Too much of data in healthcare these days is focused on making the haystack bigger, but not changing the size of the needle that the doctors are looking for. When someone's running a marathon, we hand them a glass of water or a sports drink. We don't spray them with a fire hose. Our secret sauce, we have invested heavily in educating our physicians. It's not about technology. Technology without education, I can use an iPhone to drive a nail. But how is that going to make anything better? Use a hammer for a nail. Use technology to do things that only technology can do. Doctors are really smart people. They need some education in certain areas, but then they'll do a great job if you do that. Create a team from independent physicians. You are already part of a team when it comes to the insurance plan, or when it comes to your hospital. You're already part of a team. Now, are you just wearing the jersey or are you on the field? Invest in technology when appropriate. Align incentives. Doctors will tell you that they can do great things. Just give them the right thing to do at the right time and help them to do it. And make sure that they're not being punished for raising quality. If we're going to save a bunch of money by standardizing hardware, shouldn't the physicians benefit from that? If I'm going to be great at preventative medicine, shouldn't that help my bottom line as a primary care physician? Develop physician leaders. Healthcare will not change without physician leaders. And in my area, just to be clear, we have a lot of physicians who believe that they are leaders simply because they are doctors. There is education to understand the finance of healthcare, the operations of healthcare, those sort of things that physicians need to be empowered with. They need to be trained for. Physicians talk all the time about if I was in charge. Okay, well, if you were in charge, would you be ready for the financial review every month? Would you understand even what you're seeing? Or would it be, well, that's not what I meant if I was in charge? We actually are developing a physician university to educate our physicians. with systematic training, like a little mini MBA to help them to understand things. Data transparency. You can't have transparency if you don't have data to show. Sharpen our performance and reward our performers. I honestly believe that it is only with physicians being involved and empowered and informed that healthcare will change. And if physicians don't lead change, change will be pushed upon you. Let's talk about transparency. This is a slide from a POD meeting, which is a geographic group of primary care physicians. These are independent physicians. We get up in front of a meeting of them, and this is a scorecard. And you can't see it across the top, or maybe you can. Risk-adjusted total per member per month, risk-adjusted per member per month for drug spend, admissions per 1,000, ED visits per 1,000, generic drug utilization rates, high-end imaging per 1,000. How would that kind of transparency come into your market? And if you gave that to a bunch of physicians in a room, would it be a good thing? Would it be disruptive? Okay. I can tell you that insurance companies have exactly this type of scorecard on you. I mean, if you think nobody knows that you're using that little surgery center on the side, they know. They get the claims. ED visits per 1,000 by pod. Okay, this is a list of about 60 physicians and their ED rates. And this line right here is the average for that pod. And so if you're a physician and you look at that list, what are you looking for? You're looking for your name. And I'm sorry to break this to you, but statistically, not everybody can be above average. Okay? And if your physician organization isn't showing you the data, somebody else is making judgments on it. What's your ED visits per 1,000, risk adjusted in your population? Do you have any idea? Probably not. Okay? Every physician is on a list like that in many different places. Incentives. Why the heck would I do this? For you bottom line people, fiscal year 12, potential benefit to physicians, $14.8 million. Fiscal year 13, $56 to $68 million in incentives available to physicians. Are the physicians going to get all of that? No. Can they get all of that? Yes. Should they get as much of it as possible? Yes. Okay? Look at these things. A $4 million payer, one contract from a payer with a $4 million bonus pool. Inpatient quality and safety, $6 million. Okay? Payer 3, per member per month and an increase in rate. Fee for service rate increase. That's where you want to get. I'm sorry, let me rephrase that. That's where our physicians said they wanted to get. They wanted aligned incentives that mean a lot to them. But let me be clear, clinical integration is not about the incentive payment. If you are here for the money, please leave. Our physicians are engaged in clinical integration because they are driving quality and they are being rewarded for quality. Okay? It's nice to have the financial incentives that align with it, but the best engaged physicians in my organization are the ones who are part of a team that makes a decision and it changes the care of the patient the next day. This is one physician's bonus scorecard. At the end of the year, we give this out to all the physicians. It has all of our incentive plans. It has how much they earned for each of them, where they missed money, where they gained money, puts it all together. And this is a primary care physician here, and $14,000 last year in incentive. Are you ready for it? I'm not up here selling timeshares, okay? I'm not asking you to sign up for a record and tape club and you get 10 CDs free or anything like that. I'm telling you that clinical integration is not just some little contracting strategy. It can be used to raise the quality and align the incentives for all the physicians. And I believe that medicine is changing. How many of you have heard of the bridge at Choluteca? This is one of those hot business examples that they're using these days. The bridge at Choluteca is famous because it survived a hurricane that destroyed almost every other bridge in that region. This bridge survived this flood, this storm, this terribleness, all these sort of things. It actually appeared on the brochures for the engineering team that designed the bridge. There's only one problem with the bridge at Choluteca. The river moved because of the flood. It was a fantastic bridge. It still is, although they had to tear it down because it's not doing anything now. And I'm afraid that we have a lot of physicians whose practices are designed like the bridge at Choluteca, who are doing a great job of getting over the river as it stands now, but don't understand that we have a chance of having the river move. And so maybe right now is the time to dip your toe into quality improvement and population management and being part of a team. You know, maybe it won't pan out to anything. You know, maybe it's going to come and go like the 80s or the 90s or the early 2000s. But this is the first time where the world is looking at the physicians and saying, if we put you in charge of this, how would you do? Thank you very much.
Shawn, I have a question for you. It sounds like you all have done a great job. No doubt you made some mistakes along the way. Tell us a couple of the mistakes you made so we don't make them.
This by no means has been a, golly, we got everything right. Okay, I mean, I just want you to know some of the mistakes that we've made. It's very hard to keep all of those EMRs connected and submitting quality data. I have seen some EMRs that I'm pretty sure were sold out of the back of a van in an abandoned parking lot. I've seen practice management systems that appear to have been written in Fortran by somebody's brother-in-law in the 80s. And just keeping those, I don't think you appreciate how difficult that is to get done. And Chris and I have shared some war stories, and he has more to come, so that's his fault. Another thing we did is our first contract that we wrote with our employees was a shared savings contract. And what we did is we mistakenly allowed them to reset the baseline each year. So the first year you save 12% out of a contract. The next year when you save another 5%, you only get that 5%. You don't get the whole 17% that you actually saved year over year. So now we keep a rolling baseline. It's a contracting thing. I think that you can never over-educate your physicians when it comes to these things. You need physician champions, you need leaders. I think that for mistakes, there comes a point in clinical integration where to truly be clinically integrated and to meet the FTC definitions, you have to kick people out because they're not participating. And we waited a little long to kick people out because we're all buddies, we're all friends, and you don't want to say goodbye to your friend even though they're not doing anything and they're like a remora on the shark that's just cleaning up what you've already killed. And so it took us a while to peel off the remora. I think this becomes a tool. This becomes a tool that you invent new things to do with it that you never imagined you would go after. And I think that understanding that and saying, you know, this is what we're doing as clinical integration, but it can be so much more than that. It's probably our biggest mistake, is we had some people who were along for the ride because they recognized this as opposed to all that it could be.
What's been the biggest challenge for you when approaching the payers when it comes to CI? I mean, particularly with the shared savings.
When we write a contract for our physicians, what we will do is we will say it's a raise all boats contract. So if you have an individual contract with your group, you will keep that rate, but everyone else will get a raise up. So every contract doesn't benefit every physician because some of these contracts, there's no legal way to make them any better. When we sit down with a payer, what we do is we sit down with them and we say, okay, we have this generally higher quality, lower cost network of physicians. Let's talk about benefit design. When you start sitting down with the payers and saying, what are the benefit design things you want to accomplish for your population? And it's not just a sort of a, this is the benefit design, give us a bid on it. You know, where we can sit down and have our physicians say, well, I know you think you want to do this, but this is a better way of doing it. It completely changes the dynamic. okay? And we have progressed to where we don't need a payer. I mean, we like having payers, please understand me, contracts are a really good thing for running a CI program. But if somebody comes to us and they're offering us a lousy deal, we'll walk away from it. We owe that to our physicians. And so when it comes to sitting down with them, there really is a partnership. I can tell you just as an example, Aetna. I have no idea what they're like in your market. In our market, they're working fantastic with us. Okay? Another one that's just after them in the alphabet is not so helpful. And so you sort of have to look at your market dynamics and how you're relating with the payers. What's really great is instead of sitting down with the payer, sit down with the employer and the payer. Because the employer is thinking about taking care of their employees, their friends. It's not just a contract to them. And so when we send one of our physicians to talk to an employer and we have the payer there, very often the employer will look at the payer and say, you shut up, I've heard you for 6 years. I want to talk to this physician about what they can do. And that changes the whole dynamic. Payers run the risk of getting marginalized, becoming a transaction agency, if they don't find a way to engage the physicians. Our care coordinators function as an office extension of the office. Most of our practices are so small, they don't have a person to do care coordination. And so, and that's actually very important for patient engagement. I always say that if you're a patient and you get a phone call and it's, hi, this is Mary from the Aetna call center in Tucson, you're less likely to engage as you are for, hi, this is Mary from Dr. Smith's office here to call you about your follow-up. And so they are on behalf of the physicians is how they operate. And the bigger question, how many care coordinators do you need to manage a population? Nobody knows. It depends upon your mix of Medicare and commercial insurance, and we're inventing that. I can tell you, we can't hire good people fast enough to stock up to what we need. A lot of RNs, a few social workers, we just added a pharmacist. It's very interesting as these populations go up. Some of them are general, some of them are disease-specific, chronic disease-focused, but we have a cadre of general care managers. And I'm going to summarize a little bit of your question. It has to do with collecting the data, not having it be consistent. What do you do in those sort of situations so it doesn't look like you're manipulating your numbers or those sort of things? First of all, before you had Crimson, how often did you look at your data? Okay. What? Never? Was anyone else looking at that data at that point? The insurance companies and CMS absolutely knew your data backwards and forwards. When you first look at your data is always going to be wrong the first time, okay? At least to your own mind. Because physicians don't think about the definitions of numerator and denominator that factor into their numbers. What's your specialty? OBGYN. What's one of your measures that was wrong when you first looked at it? Surgical complications. One of my facilities, we had a coder who was coding every postpartum anemia as a complication. So it was skewing the numbers, okay? It may be, there's 90 different things that can be wrong with your data. The most important thing about looking at your data is that you're looking at your data and that you understand that it needs to be sharpened. And it usually takes about 3 times of sitting down with the coder who's understanding why they're calling this a complication when the doctor never called this a complication, or why you didn't say the magic word which made it a complicated case versus a non-complicated case. And so for me, the value of Crimson, and just for disclosure, I'm one of the people who helped design what you're dealing with now. So you're welcome and I'm sorry, both of those. Crimson is collecting all this information and putting it there to where you can see it with a level of transparency to where you can engage in fixing the numbers so that you're in better shape when it does get out. Because all of that is getting out. I once was talking to a group of surgeons and they voted unanimously as a surgical department that no one would release their Crimson numbers. They felt that it was too incorrect, that no one was to release those numbers. And I said to them, I have never released a single Crimson number, but all of that data is going out. And so if physicians don't engage in looking at it and not just discounting it because it's off, but understanding that until you correct it, that's what you look like. Every doctor is being distorted by a funhouse mirror of their data, and until you get in there and flatten it, it's not correct. Now, some doctors look better than they are. because of the data. And some doctors look worse, but no doctor is 100% accurate when they first look at their data. So what do? We work with our doctors and we say, this is your data. What's wrong with it? What needs to be improved? Do you need to sit down with a coder to understand how this got coded this way? Or do you need to understand? Let's look at the definitions. I had a physician who wrote all the prompts in his EMR incorrectly for a reminder for mammograms. And we sat down with him and we said, okay, your numbers are worse than the numbers you're getting out of your system. Why is that? He'd written his EMR wrong. He never would have known that, and he'd have been wondering why his government website said on Doctor Compare that he wasn't doing as many mammograms as he thought he was doing. But until you look at it, Crimson becomes a focus for people. Absolutely look at your data, know your data, and understand that until you fix it, no one's going to, because nobody cares as much as the physician who's attached to that data.
Shawn, thanks very much.